surgery. So in this course, my co-instructors would be Dr. Gayatri Ahuja. She's a prolific refractive surgeon and will be dealing on epithelial thickness mapping, how far significant. Evolution of refractive surgery, Dr. Mamta Singh, who is a faculty at AIMS Rajkot. Myself will be dealing on the PRK Knowing Your Limits. Dr. Subhash Prasad, who has an experience in refractive surgery on the various nightmares a clinician can face. Professor Raki, she's a professor in cornea and refractive service at Patna. She'll be dealing on how to manage the pain. And Dr. Mohita Sharma will be dealing on surface ablation gross sleeve, a smooth road to future. So I now welcome Dr. Mamta Singh to speak on evolution of refractive surgery.
Can I have my slides, please? So good morning, one and all. In the meantime, let me convey my thanks to Dr. Nilesh Mohan, sir, and AIOC for giving me this opportunity. I am going to talk about the evolution of refractive surgery and how we have reached to the current status, whatever we are doing these days. Yeah, that's the one. Thank you. It's not... Do I need to change the podium? I cannot see it here. No, not. अभी शायद आएगा.
Ma'am,
चलेगा. Now this is visible, perfectly visible. Yeah. So let's start. We all know that these surgical procedures are meant to correct the refractive error of human eye. But if we go to the story, this entire saga of development of refractive procedure, then it is more than 100 years old. It started way back in 1896 when Lance used some heat-based devices, something like a cautery, to correct the refractive error. And it's very fascinating that each of these procedures, they have got their own story of development. Each of these, they started somewhere in a laboratory, in an experimental setup on animal eye. And depending on the success of that, we shifted to the non-sighted individuals or blinded individuals. And if we were successful there, then we shifted to sighted individuals or the normal human eye. And depending on the success result of that, then the procedure came into market. Once the procedure has established itself, it gets the FDA approval. And it takes nearly 7 to 9 years to get the approval. And in spite of that, if the procedure is not delivering what it claims to deliver, then the FDA approval can get retracted. Something like that happened with thermal laser keratoplasty. So basically, we divide these procedures into two types, corneal and lenticular. We are not going to talk about the lenticular procedures anymore right now. Corneal we divide in incisional and laser-based. So it all started in 1939 by a Japanese scientist, Sato, who started radial keratotomy. The idea was very simple, to put multiple linear incisor in the paracentral or the peripheral area, thus the central area get flattened. But what Sato was doing, he was putting the incisor both on the anterior as well as the posterior aspect of cornea, that is both anterior and posterior keratotomy. So when this procedure was adopted by USSR and then in US, it's like 20-year gap was there. So by that time, the follow-up patients of Sato or the patients who were operated in that era, they were there in the market. So it was there for everyone to see that nearly 75% of these patients, they had developed bullous keratopathy. And that is the reason when US started RK surgery, by that time they had stopped doing posterior keratotomy. For the simple reason, now they know the advantage of or the role of corneal endothelium in maintaining the clarity of cornea. So when in US they started, they did two large studies. One is PERC, that is prospective evaluation of radial keratotomy, and another is ARC, that is analysis of radial keratotomy. And based on the 10-year data, they concluded that nearly 70% of these patients, they get the optimal visual correction. But hyperopic shift was a problem. And that was because when they were putting an incision, the inflammation which creates during the healing process, that affects the surrounding tissue also. So they wanted something which can do the job precisely without affecting the surrounding corneal tissue. So the answer was laser. It got invented in 1983 by an Indian scientist, R. Srinivasan, who was working at IBM during that time, and he had 21 US patents in his name. So he was using this laser, this excited dimer laser, for photo etching the computer chips. When his paper was read by Trokel, he got this idea that probably we can use something like this for corneal tissue also, because every photon of this excited dimer laser has got sufficient energy to break the bond between carbon-carbon and carbon-nitrogen bond, which is there in the corneal collagen. That is how the concept of photoablation came into picture, and it was given by Trokel and Srinivasan together first time. And that is how it happened. So if we talk about the major advancement, it has happened at two places mainly. One, advancement in laser technique. Another, how we are going to approach the area where we are going to do the modification, how we are going to reach there. That is where the advancement is. So if we talk about approach, obviously the first would be surface, because that is easily accessible. So we have multiple type like PRK, LASIK, EPILASIK, and trans-PRK. Not necessarily they have been invented in the same chronological order. But the idea here is to remove the epithelium and apply laser. This removal of epithelium can be achieved in multiple manners, be it mechanical, chemical, by using alcohol, or photoablative epithelialization, that is by using the same excimer laser. So in PRK, as I said, the idea is simple here. We can see it here. Remove the epithelium and put the laser. But when you are removing it mechanically, you are creating nick in the Bowman's membrane. And then when you remove it, you're not going to get a smooth surface interface here. So what we decided to do, we started using this alcohol well. That will loosen the epithelium, and now we can remove the epithelium. But if we do not remove the epithelium, simply make it one side like a flap, this became LASIK. But if we do the same without using this alcohol well, by using a microkeratome which gives a very thinner cut, that is epikeratome, this became LASIK. And finally, the transepithelial PRK, where we are using the excimer laser first to remove the epithelium, and then we will be doing the ablation in the stroma. And we'll create this ablation profile in such a manner that there is a smooth transition from epithelium to stroma. But the problem here is, when we are cutting when we are putting the laser over Bowman's membrane, we are destroying it. Plus, there is a huge neural network in the anterior part of cornea, which is also getting destroyed. So the idea here, probably it adversely affects the healing process, and that is the reason why LASIK came into picture. What they decided to do, they wanted to make a cut, shift the entire thing, the Bowman's, the neural network, to one side and then apply laser. So that was given in 1990s by Palikaris and Burato, and they called it flap and zap technique. Probably those PRK, they will try to negate my point that nothing like this happens, but that is how it all started. LASIK came into picture. So as I said, there is a development in laser also. As we started from first generation, that is preclinical, to now we are at the 6th generation of laser. What started as a broad beam, now we have a very small beam. So we can precisely ablate a particular tissue. But what is needed here, we have to reach that tissue. So there has to be a tracker mechanism. So as the laser got advanced, the tracking mechanism also got advanced. So in 6th generation, finally, we have a mechanism to negate the cyclotorsion effect also. So that is how the laser also, the excimer laser also advanced. So if we talk about now customization, mainly we have 3 types. One is wavefront optimized, one is wavefront guided, and another is topo guided. In wavefront optimized, what we are doing, we are taking the aberration data of population average. We are taking the patient's cornea, do the ablation, and try to reach it to the population average. We are not considering the individual factor here. We are considering the population average and try to make it there. In wavefront guided, what we are doing, we are considering the higher order aberration of the given patient, and then we are trying to smoothen it to make it ideal. In topo guided, what is happening here, we take the topographic data of the patient, the elevation point, depression point, and then we compare it with the ideal topographic picture, and whatever up and down is coming, we will be ablating it. That is how the customization was happening. But whatever we are doing, If we are using the microkeratome, the problems were still there because of so many flap-related complications were there, decentered, thinning, free, etc. So now we became more greedy. Now we wanted to have someone who can do the job for us precisely. And that came in the form of femtosecond laser in the year 2001. This is basically a near-infrared radiation which causes photodisruption. It strikes the tissue, it creates plasma. Plasma is nothing but electron and ionized molecule. So that spreads, that creates a cavity. So there is a clear-cut distinction, clear-cut demarcation. And the best part, it does not cause any heat, it does not cause surrounding inflammation. That was the advantage of femtosecond. And if we compare the flap which was created by microkeratome and one that has been created by femto, then we realize that it has got better adhesion, smooth interface, obviously more precise, can be fully customizable. And as this is cutting in one plane, this is going to be planar. LASIK we cut in this manner, so they cannot be planar, obviously. There are different set of complications, different from what we get in microkeratome, but obviously they have their own complication, and visual acuity is supposed to be better here. So now we have this femtosecond LASIK, but again we are finding it problematic because now we need to create the flap with femto. Then we need to shift the patient to excimer laser. These two laser platforms are needed, so obviously you are paying like bucks and bucks of it. And then the patient, the entire time duration is extended now. So now there is another concept which came into picture. Why not let's go totally dependent on femto only. I will quickly take 1 more minute just. So that gave us the RILX, or what we call KILX now. So they created the flap with femto. They removed the lenticule through this flap just by using the femtosecond laser, and the more refined version of it we have in the form of SMILE. That is, here we are not going to create a flap. What we will do, we will just make a small incision which is like 1/5 of the total thickness of this flap, and through this we are going to take the lenticule out. Here the advantage is we do not require to elevate the flap. We do not need to transfer the patient from one platform to another. And as this lenticule is created in the mid-stroma, so anterior portion of cornea is maintained here. Anterior portion of cornea where the collagen is so densely packed, that gives the maximum biomechanical stability and that preserves the nerve. So the dry eye chances are less and the cornea reserves more biomechanically stable. And another refined version was by Johnson & Johnson, no financial interest here, is in the form of silk that we are talking these days. Here the difference is, it's like the lenticule which we cut normally is plano-convex. This is biconvex. It is supposed to be more precise. These are the different KILX platform that is available in market: silk, SMILE, clear, smart sight. These are the different ones. So this is the fascinating story of evolution of refractive error from my side. Thank you all of you.
Thank you, Dr. Mamta. You have very nicely explained the transition from the mother of refractive surgery, PRK, to silk. By the time the next speaker comes, I request Dr. Subhash Prasad, Professor Rakhi, and Dr. Gayatri Ahuja to be here on the stage. The next talk would be on epithelial thickness mapping. How far is it significant when PRK is resurfacing itself in use nowadays? So how far is it significant? Should it be measured? Does it make a difference? Dr. Gayatri Ahuja, she has a vast experience in refractive surgery, and she will be putting an insight into that.
So good morning, everyone. And firstly, I would like to thank Professor Nilesh Mohan sir for including me in this IC. And my topic for today is epithelial thickness mapping, how far significant. And my aim for today is to convince everyone that it is extremely significant, and I hope I succeed in it. So the epithelium, as we know, along with the tear film, represents the optical interface and plays a critical role in the refractive power of the eye. The power of the epithelium alone ranges from 0.5 to 1.85 diopter at the 2 millimeter diameter zone. Therefore, small changes in the corneal epithelium thickness can cause significant refractive changes. The normal epithelial thickness is about 54 micron, ranging between 50 to 60 micron, and it is non-uniform in pattern. The superior being thinner than the inferior and the temporal being thinner than the nasal. And this is due to blinking and the friction of the upper lid, which is more superiorly and temporally. Now, what we need to keep in mind is that the epithelium is not of homogeneous depth over the Bowman's membrane. It compensates for stromal surface irregularities, becoming thicker over valleys and thinner over hills. Like this is a patient of ectasia, advanced ectasia, but over a period of time, the epithelium has remodeled itself in such a way that if we do a topography, we might just miss the ectasia. So the anterior cornea starts looking smoother on topography as compared to the underlying stroma, and therefore assessment based only on topography with no knowledge of epithelium can be misleading. So there are various tools which are available in the market to measure the corneal epithelium, and the anterior segment OCT is the most widely used because it is non-contact and very fast, and MS39 is the most recent one with the highest resolution. So ETM has multiple applications. It is an additional tool for early detection and monitoring progression of ectasia, and also for following up post-C3R patients, and it has a very important role post-refractive surgery in managing post-op refractive surprises, preoperatively for safer screening, and also in the surgical planning of transepithelial surgeries, LASIK flap depth, and enhancements. So in keratoconus, what we have is a localized zone of epithelial thinning, which can be seen here over the cone, and this is surrounded by an annulus of thickened epithelium, and this is the classical donut pattern. Epithelium is highly irregular in keratoconus with very large map variations, and point over the cone being up to 30 microns thinner than the thickest point at times. Now this is a patient of keratoconus with a scar. So there is thinning of the epithelium over the cone, but in the center where the scar is present, there is thickening of the epithelium, showing that if a thin area is flat, like a scar, the epithelium will thicken over it, proving that the epithelium responds more to the underlying curvature and not to thickness per se. So ETM also helps in distinguishing ectasia from pseudoectasia, which is extremely important from a refractive surgeon's point of view. Pentacam will show steepening in both warpage and ectasia. ETM will show maximum epithelial thickness corresponding to the steepening in warpage and maximum epithelial thinning corresponding to the steepening in ectasia. Now this is a patient of a contact lens wear who is using contact lens only in the left eye for the past few years. So the right eye is absolutely normal topographically, and the ETM is also absolutely normal. But the left eye is showing elevation in the anterior curvature map, and the epithelium thickness profile in the left eye is showing generalized thinning and thickening over the central region corresponding to the elevation, enabling a diagnosis of contact lens warpage. It's extremely important in screening patients for refractive surgery, and studies have found, very interestingly, that larger patients are screened in with the epithelial maps then screened out, and this is because pentacams tends to overdiagnose keratoconus and gives false positive results. So this is a suspect case with a steep K of 49 diopter and a total D of 2.1. But the ETM over here is showing very regular epithelium with no areas of thinning. So the patient was confirmed as normal on ETM and screened in. This suspect case has a thin cornea of about 450 micron and a total D of 2.1. So here again there is no thinning in the epithelium. In fact, there is thickening of the epithelium in the center, and this patient was also confirmed as normal and screened in for surgery. This patient had a Kmax of about 49 diopter and a total D of 1.7, which is borderline. But the ETM here showed the classic donut pattern which is seen in keratoconus with thinning surrounded by thickening. So the patient was screened out, confirmed as keratoconus and screened out. The other eye of the patient, which was absolutely normal topographically, was also showing irregularities in the epithelium. So post-refractive surgery, it also helps in differentiating between early ectasia and regression. In ectasia, there will be thinning over the steepest portion of the cornea, while in regression, there will be thickening in the central zone corresponding to the flattened area post-refractive surgery. And it also helps in monitoring post-op changes, and this is extremely important when you have any post-op refractive surprises. So post-surgery, the epithelium remodels in response to both curvature and thickness, thickening an area where curvature has been flattened, and thinning where it is steepened, and also thickening to compensate for the stromal tissue loss. What we need to remember here is that epithelial thickness increases proportional to the spherical equivalent corrected. The response to curvature is more than the response to thickness, and it does not usually affect the visual outcome. So these are a few post-LASIK ETM maps. In myopia, you will find thickening in the center corresponding to the ablated zone and thinning in the periphery. And in post-hyperopic maps, you will find thinning in the center corresponding to the area which has been steepened and thickening in the periphery. Irregular epithelial remodeling can sometimes be seen as an atypical response to surgery due to some interface of flap complications or due to epithelial abnormality. And these atypical responses can sometimes lead to regression, unstable refraction, and diurnal fluctuations in the vision. So this is a patient of a post-op refractive surprise who presented to us about a month after LASIK with a sphere of -1 in the right eye and a cylinder of -1.5 in the left eye. The ETM showed generalized hypertrophy of the epithelium in the right eye and abnormal focal regions of epithelial modeling in the left eye. So the patient was put on medical therapy with steroids and anti-glaucoma medication, and they typically respond very well to it. At the end of 1 month, the epithelium had regularized and the patient had regained a vision of 6/6. So here again, we need to remember that the largest epithelial response takes place only in the first month. And the earlier these atypical responses are picked up, the better they will respond to therapy. This is a post-hyperopic LASIK patient who presented with aberrations, glare, and diurnal fluctuations. The ETM showed a lot of irregularity with fracture lines. This patient was also put on medical therapy. The epithelium remodeled and the quality of the vision improved by the end of 2 months. Post-LASIK DLK also shows a lot of irregularity, and the good news is that this also responds to treatment, though it might take a little longer time than the other cases. Post-PRK remodeling shows increase in the central epithelial thickness in the post-op phase, and this typically stabilizes by the end of 6 months. Increase in the central epithelium, the long-term comparison between LASIK and PRK does not show any difference in the epithelial remodeling, and it does not really affect the vision. Post C3R, ETM is the most sensitive method to monitor progression. This is the patient of keratoconus showing thinning over the cone area. 6 months after C3R, there's a lot of thickening, but still a lot of irregularity. But by the end of 9 months, the epithelium has smoothened out and there is thickening of epithelium over the cone region. You can compare it with the pre-C3R map. So this is very nicely smoothened and thickened out, and this indicates a successful treatment. In cases of failure, the ETM will continue to thin out. Now this is also very important in planning refractive surgeries, and the rule that the epithelial thickness is 10% of the total corneal thickness does not always apply. Here we have a patient with an absolutely normal topography with a very thick epithelium of 120 micron. And here you have a patient with a normal topography with very irregular thin epithelium due to dry eye. So inputting arbitrary figures and planning procedures without epithelial mapping can lead to refractive surprises, suboptimal results, and flap-related complications in LASIK enhancements as well as PRK. So this is also very helpful when you're trying to customize treatment, especially in cases of keratoconus, when you're trying to plan a TREC or a TCAT, when you need to identify the epithelial thickness on the thinnest location to plan the treatments. Like this is a patient of keratoconus with the epithelial thickness of only 20 micron over the cone. So this is highly significant when you're trying to plan some treatment. And also in PTK cases, when you're trying to treat corneal irregularities or any post-LASIK flap complications which you want to smoothen out by PTK, you need to know the exact epithelial profile and the thickness in order to get optimum results. So to conclude, epithelial thickness mapping is an important tool in the refractive surgeon's armamentarium, and it has a role in the screening, planning, and post-op evaluation in refractive surgery, but interpretation should always be made in context with the clinical findings and topography. Thank you.
Thank you, Dr. Gayatri. You very crisply explained the importance of epithelial mapping. But one thing I would like to just ask, ma'am, if you're doing a PRK and you don't have an exact epithelial mapping, can you proceed with a safety? I mean, post-op response after PRK in the initial days shows an epithelial thickening. Later on, it gets remodeled. But can you move ahead with a standardized?
So the best thing is to have an epithelial thickness map, but many cases will be okay because mostly it is around 10% of the total corneal thickness. So you will be fine in most of the cases. But there will be a few cases which will surprise you. So it is always good to have an epithelial thickness mapping.
So, thank you, ma'am. Definitely, your data have definitely suggested that. I mean, it would be definitely a more accurate tool when you are going ahead with your epithelial mapping. Thank you so much. In the meantime, I would request Dr. Mohita Sharma to please come up on the dais. And Dr. Mamta, where are you? Please. Our next stop, we will be proceeding with, now we have done the epithelial mapping. We are ahead with PRK. Now, surface ablation and pain management. That will be dealt by Professor Rakhi Kushumesh. She is a professor in the Cornea and Refractive Services with us at RIO Patna.
Good morning, everyone. First of all, I would like to thank Professor Nilesh Mohan sir for giving me this opportunity. So I'll be presenting a very relevant and practical topic in the surface ablation, that is pain management. I have no financial interest. Before going into the discussion of pain management, just let's see why PRK is still relevant in the era of LASIK, femtolasic and smiles. Because definitely PRK has few advantages over LASIK, that it causes no flap related complications. It is more suitable for the thinner corneas. There is reduced risk of dry eyes and safer choice for the person who is athlete and in the armed forces, and of course the long-term corneal biomechanical stability. But the biggest challenge in these cases, why the patient and the doctor both hesitate when it comes to PRK, that is the post-operative pain. And this is not just a theoretical concern, this is what we see on day one, the typical PRK look with redness, photophobia, watering, anxiety, restlessness in the patients. So in this presentation, I'll deal with the why pain occur and how can we manage it effectively. So first of all, the pathophysiology of pain, and here when we remove the epithelium in the procedure, it triggers the release of inflammatory mediators and that sensitize the corneal nerves. And after laser ablation, when it ablates the stroma, it also affects the deeper axons and also the keratocytes, which further amplifies the inflammation, and this sensation actually travels by trigeminal nerve to the brain, and that creates a sensation of intense pain. So in follow-up period, in the healing phase also, when the nerve degrowth occur, there can be a formation of microneuroma, and this is the basis of some time patient feel persistent discomfort in first few months of the procedure. Now this is a typical course of post-PRK pain, and here in this graph you can see that the pain is highest within first 24 hours following the surgery, and it then gradually slows down in 72 to 96 hours. And this pattern of pain following the surgery actually correlates with the process of reepithelialization. When the epithelial defect completely heals, the pain completely subsides. So there are several strategies through which we can minimize this post-operative discomfort, and these include mechanical protection with the help of BCL, temperature regulation by corneal cooling measures, and judicious use of medications in the post-operative period, and choosing the right laser ablation profile and epithelial removal techniques. So I'll take one by one, and they all works in a different ways. So the most common method which we use to reduce this post-PRK discomfort is the application of BCL after completing the procedure. What it does, it actually provides a physical barrier, covers the exposed nerve endings, and at the same time it also supports the epithelial healing. So among BCLs, we prefer using the BCLs with high oxygen permeability that translate better comfort to the patients. And at the same time, we should be careful about the risk of infection, because chances of infection in PRK with BCL is relatively higher than the LASIK cases. Now the most simplest method that we can do to reduce the post-PRK discomfort is the corneal cooling measures, and the reason behind this that when we do laser ablation, when the tissue ablates, it creates some kind of heat, and that raises the temperature of the ocular surface. And with the rise of temperature, it stimulates the temperature sensitive nociceptor, and that lead to pain and discomfort. Now the corneal cooling works in two ways. First, it drops the temperature of the surface, and second, it washes away the pain related mediators, mainly the prostaglandins, that lead to pain and discomfort. Now there are several ways to do this corneal cooling method. With the chilled BSS or the sponge soaked with BSS, or you can use the cold patches in post-operative period, and also the chilled BCLs. So there are a number of studies available which have been done and compared the chilled BSS with room temperature BSS, BCLs and everything. But the results are not very conclusive. Even though the results are not very convincing to us, I feel using chilled BSS during the surgery can help a little. It may not make a big difference, but definitely it can take a small step towards the pain relief. So now, apart from these methods, we have to consider some pharmacological ways to overcome this problem. And just look at this inflammation pathway. You can see that corticosteroids acts very broadly, while NSAIDs blocks the COX enzyme, and thus it stops the production of prostaglandin, which is a main mediator for pain, and thus gives the immediate relief. There are multiple studies have been done which molecule is better and which works better. Definitely they are better than the control group, but among them it's very difficult to say which molecule is better. Only two molecules and NSAIDs are FDA approved, that is diclofenac and ketorolac. And diclofenac gives inferior analgesia in comparison to nepafenac, and there is only one molecule which doesn't delay the epithelialization, that is flubibufen. If we compare topical and systemic administration of NSAID, then there is no difference. Majority of studies don't support this. Now, pre versus post, both reduces the post-operative pain. Combining topical and systemic NSAID is not going to give any added benefits. And there is a recent study from NN group using the non-preserved ketorolac soaked BCL, which significantly reduces the pain. Now, it's true and it's proven that NSAIDs give relief in the post-operative period, but it is not at all risk-free. There are a number of studies which shown that every molecule of the NSAID, they delay the reepithelialization, and as I said that the period of maximum discomfort actually correlates with the time required for epithelial defect. So it delays the reepithelialization and thus prolong the period. But definitely it gives the relief a little bit. And apart from these, it can causes some severe complications also, like it may lead to the corneal melt, sterile corneal melt, and as well as sometimes there are some reports showing the corneal infiltrate. So here comes the this NSAID we cannot use very in all the patient. It comes with a cost, and that is the delayed epithelialization. So we know when and how to use these drops in post-operative period. Another thing is that is steroid. On the contrary to NSAID, it may not give the immediate relief to the patient, but at the same time it doesn't delay the epithelialization, and it inhibits the formation of haze, and it gives a long-term comfort to the patients. Now there are other medication have been documented in the literature, the use of topical and systemic opiates, cycloplegia with hometropine and topical anesthetics, but the uses are really less in practical routine cases. Now coming to the epithelial removal technique, there are a number of techniques as we have just seen in the previous presentation, that LASIK, EpiLASIK and PRK. There are multiple randomized control trials have been done comparing these techniques, and they found that there is no big difference in the epithelial removal technique in LASIK, EpiLASIK and PRK. But point to note here that transepithelial PRK with the flying laser spot definitely gives lesser inflammation and less discomfort in comparison to the other types of epithelial removal technique. Now in laser type, if we are providing a good smoother ablation profile and the lasers with lesser collateral damage and more precise ablation, definitely the better laser technology gives smooth ablation and definitely lead to faster healing of epithelium and so the lesser pain in the post-operative period. Now, how I deal with my patients in pre-operative period, I thoroughly evaluate the ocular surface of all the patient, including the corneal sensation, and I spend lot of time in counseling so that they know what kind of pain they might have in the post-operative period. Definitely, I am not, I don't want to scare them, but I want to convey that this kind of picture you will have in the post-operative period so that you won't be scared. And I start topical antibiotic and the topical NSAID 2 days prior to surgery and give NSAID immediately before the surgery as well. In intraoperative period, I prefer doing transepithelial PRK with good irrigation after laser with chilled BSS and application of BCL in all the cases. In post-operative period, I prefer giving antibiotic and steroid combination. If patient is very anxious and apprehensive, then I add the oral tramadol along with the NSAIDs. And I always advise to use the artificial tears, the cold and chilled artificial tears frequently so that they feel comfortable in the post-operative period and avoid the sunlight exposure. So this is a picture when we don't follow any kind of pain management protocol, and this is a picture on day 1. And if you follow, you add something, you cannot make the patient completely relaxed, but definitely you can reduce the pain score on day 1 and patient feel little comfortable if you don't follow anything. Thank you.
Thank you very much, Dr. Aki. This pain is a concern of the surface ablation which led to its non-use by the ophthalmologist, and different technologies came definitely. But counseling was very important part which has to be dealt with the patient. The patient should know what is going to happen the next day, because these kind of demanding patients usually come, they think that it's a minute procedure, everything will be fine. So it will be fine, but it takes the transition. What she highlighted was up to around 96 hours. The maximum is within 24 hours. So very nicely explained, Dr. Aki.
Thank you so much.
Very nice presentation, Raki. Just what I do in my patients that I use some diluted topical this proparacaine drop for initial 1 or 2 days. That really helps. I have found difference in the patient comfort. So in my experience, that has worked.
Oh.
No, trans-PRK.
That is also one option.
It is for 2 days, or you continue it
just for 2
week?
days. Just
2 days.
Because the first 24 hours is the most painful. Then gradually it comes down.
So how much dilution do you do in topical
4 times a day.
4
So
times.
won't it be epitheliotoxic? I mean, at that point of time, the
But,
epithelial healing is
I
going
ask
on.
patient to put maximum 3 to 4 times in initial 1 or 2 days only, not more than that. Not that you keep on putting for every hour, so know that.
Does it extend the epithelial healing period, or it remains
Generally,
same?
I remove all the BCL of my patients are removed 4th or 5th day.
Fourth
So
or
by
fifth
that
day.
time, I have not found any difference even when I was not using this.
So because many people, I
Dr.
mean,
Mohita has more experience in that.
Yeah, we do the same. We used 20% diluted proparacaine eye drops, where 80% is lubricant and 20% is proparacaine, and we use it on the first day, on the day where the procedure has been done, and the patient has to use it 3 to 4 times on that day itself, and we call the patient on the 4th day for removal of the BCL directly on the 4th day. And in fact, we have seen that our patients don't complain of pain. We used to get patients when we were doing PRK. The patients used to give us call in the at night and say, shouting with pain. They used to say that my eye something has gone wrong with the eye. That is totally gone now. In fact, that's what something I will share in my presentation, and it's become a beautiful procedure with this and few other things added. And in fact, the pain score is so low that sometimes we try to ask leading questions. Initially, we also couldn't believe, and we used to ask them, you didn't have any pain. Normally what they will say is that little bit of burning on the first day, and that's all. And no, I don't think it is epithelial. It is, otherwise it is epitheliotoxic, proparacaine, but if we are giving only 3 to 4 drops on the same day, next day onwards the patient is comfortable anyway. So it does not delay healing. Anyway, the epithelial healing in transepithelial PRK is faster compared to PRK, because we have a more regular cut and all in the epithelium. So 4th day we find that 99% of our patients don't need the BCL any longer.
So you use it for only one day?
Only one day.
Okay. That's great, ma'am. So thank you, Dr. Rakhi. Yeah, question? Yeah, sure. Mic. That is what I asked. I mean,
it's only 3 to 4 drops. And yes, even in fact the BCL also we soak it in any nepafenac like Amplinac and then use it. We don't see any traumas to the cornea, and this is what we have been doing for last 1.5 years. More than 150, at least more than 150 to 200 cases, and they are all doing well.
And BCL you soak in?
Amplinac, any nepafenac.
Previously,
it was recommended to do it in AccuVale because it was preservative free. It used to come from Allergan, but now AccuVale is not available, so we were a little scared using it in Amplinac, but we now regularly soak 20 minutes before the procedure. We will soak it in the contact lens in Amplinac. I'll show you. I have a short video for that, and then we put it in the refrigerator so that it becomes chilled also, and then we put the.
I usually give NSAID after the
that is a good choice.
I soaked in only 2 patients, and those 2 patients they did not reepithelize. So I was
so that must be by chance, because we have more than 150 patients and they try once more.
I'll lead Karan.
I can understand your apprehension. Even we have never done this. Even I don't like to soak the BCL or give paracaine. But even if you're using cold contact lenses and using chilled BSS and using something like a ketorolac thrice a day for 3 days, even that is enough. Even then the patient doesn't complain of pain. So
that is working now.
A cold is an extremely important factor.
Whatever is working, we have to get rid of
pain
the
has to be managed. That's important. I mean, that's not the epithelium. It's not affecting the epithelium. Yes.
Yes. Most important is one, you have mentioned in your slides that you are using NSAIDs prior to the surgeries 2 days before.
Yeah.
Second, you are talking about using cold eye drops. What's the rationale behind using it before the surgery, and how much temperature the drop should be? And third, can you use cold eye patches?
The exact temperature cannot be said. That I keep the BCLs at least 1 or 1.5 hours in the refrigerator before the use. So temperature can't be measured in BCLs, how much temperature is exactly at that time. The use of NSAID prior to surgery gives, because I don't want to give NSAID in the post-operative period. So for me, the safer option is to give NSAID to keep the inflammatory mediators or any cascade down prior to surgery, so that patient would have a little better comfort than without any NSAID or without any measures.
But won't it increase the chances of corneal mites?
No, we are not using it in the presence of epithelial defect. We are using it.
People are even using it after the
epithelial
surgery.
on. So the chances of corneal melt in that cases are very less.
Because there have been reports of corneal melt with nepafenac. If you can study the US data, nepafenac is very much less used in their.
We use nepafenac very commonly in the cataract cases also.
They have, if you will find in their pharmaceutical industry, you will find it very rarely used.
Yeah.
So So there has to be some.
So in these sessions, we are, all the literature can be saying anything, but these sessions are meant to share our practical experiences and what is happening on the practical level. So that's what Dr. Rakhi is trying to say.
Can we use
The chances of a sterile perforation with any kind of NSAID is definitely present. But how much percentage is going to happen in what scenario, it is important for us.
The debate is whether to use a steroid versus NSAIDs pre-operative. Should we be using NSAIDs or should we be using steroid pre-operative?
No, why steroids pre-op?
Pre-operative because she mentioned that she wants to bring down the inflammatory markers. So instead of using an NSAID.
No, I'm not using steroid in the pre-operative period. Better to use NSAID because we don't want to make the surface and the local immunosuppression. We just want to inflammatory mediators at the lowest level. We don't want to immunosuppress the local area, the ocular surface.
Dr. Rakhi, I think many answers may come in Dr. Mohita's slides. So you will get the answers, I hope so. We'll continue with this presentation and I'll take your question just after this. So when these things have happened, now I'd request Dr. Subhas Prasad to speak on refractive surgery nightmares. He's a prolific phaco surgeon as well as a refractive surgeon practicing and director of Divdrishti Eye Center at Patna.
Thank you, Professor Nilesh. So the topic of the today's meeting is the resurgence of the surface ablation, and this is one of the causes of resurgence of the surface ablation. So we all know that LASIK requires making a good flap of a particular thickness, and for that you need to apply a good suction. And it was when invented in 1990 by Pellicaris. It has gone a lot of improvement, not in technology but the understanding of the procedure itself. And nowadays, till few years back, it was considered to be the best, one of the best refractive procedures for taking care of the refraction of the eye. And though it was safe, effective, efficacious, but it is not always without complications like any other surgery anywhere in the body of the person. So this is one which is known to have certain complications. Though it is very safe, the complications are very rare. One another important thing is that though the complications are there, but reportings are not, or documentation not that proper, because most of us are not recording the video or the surgical procedure like in phaco surgery or any other procedure where our microscope does have the attachment, the camera, but here in the LASIK procedure most of us are not recording. So it's very rare to have very good video for the any complications. So this is just some of the intraoperative complications. Just going back to this slide, I would say that most of the complications which are nightmares what we face in the LASIK is all because of the during the flap creations. So this is small thing which can happen with anyone during the procedure, even if you don't apply suction, but due to just manipulation of the conjunctiva. So what is most important is to have a very good suction, and good suction is required to not only to stabilize the globe, but let the cornea prolapse into the ring so that the proper depth of the flap is made. And if there is suction loss, then it can create a lot of problems. So that is most important part, and all of us are so much scared of the suction loss during the procedure. So what are the causes of suction loss? Most of the time it is there in the patient's eye. If we are not taking preoperative care, like patient has narrow palpebral aperture, very apprehensive patient, deep set eye, flat cornea, there is improper position or eye of the patient, and there is improper application of suction ring, and you have not properly chosen the size of the ring, you have not applied properly the suction, and if the suction pressure is low, and if there is sudden movement of the patient's eye, it can cause loss of the suction. And these all things has to be taken care of pre-operatively, and during the procedure we have to just keep telling to the patient, just remain calm, because it is very frightening, not only for the patient but for the surgeons also. And believe me that this is one stage of the LASIK surgery while doing the pass of after making this suction. When we pass the microkeratoderm, that is one time when our heart starts beating a lot. So that is the time when we ask the patient to remain calm and always maintain the fixation. And one should avoid draping while draping. One has to take care that you should avoid all the ILSs in the surgical field, so that it doesn't come. And if suppose there is suction or it has happened, then what are you going to do? if the flap if the flap has already been made, which is more than the intended zone of the ablated zone, you can go ahead and do the procedure. And if there is hinge in the ablation zone, then you have to abort the procedure. You cannot go ahead, either retreat after 3 months, and if you are planning for surface ablation, you can do little earlier, but at that point of time you have to just abandon the procedure. These are the small problems which can occur, but that is not much of importance. But only thing is, only care you have to take that if the epithelial defect is bigger, you have to apply bandage contact lens. The complications which are related to the flap are decentered flap. If you are not properly applying the suction ring, then it can create decentered flap. And if you are performing a pupil centered ablation, then the patient's visual outcome may be unexpected. So if you find that the flap has been made which is actually decentered, then it's better to abort the procedure, and you can do the re-laser if sufficient time has passed, say around 3 months. And one thing which is important to see is that if the expected gap between the peripheral edge of the ablation and flap margin is less than 1 millimeter, then you can do the procedures. Incomplete flap is also mainly due to the suction loss and malfunctioning of the microkeratome, which we can encounter. Sometimes you can end up with a flap tear, but if the flap tear is just in the periphery, you can just lift the flap from the other side and go ahead with the procedure. And if it involves the ablated zone or the central area, you cannot complete the procedure LASIK. You can just wait for another few weeks for surface ablation, or you can redo in 3 months. Buttonhole happens only when you are again not taking proper preoperative care and intraoperative care. Like if you are planning to do LASIK in a patient who has very stiff cornea, be careful. If there is suction loss, you should avoid that problem of suction loss. And if you are planning for large flap, and it happens most of the time in the second eye, reasons being that the cornea gets dried, and there are more chances of the buttonholing of the flap. It can result in the irregular astigmatism and epithelial growth, so it has to be managed well about the procedure. And again, the principle is to do the retreatment 3 months after the complications. Pre-cap is again one of the most dreaded nightmares, which happens to all of the LASIK surgeons once or sometimes in their lifetime. And if it occurs, the reasons being again mainly due to malfunctioning of the old or microkeratome. The cornea is very flat, less around 40 diopter of the keratometry reading. If there is decentered suction ring, and the patient again, if the patient has not cooperated well, then it can lead to the free cap. And you can prevent this very well if you take all the preoperative cares and intraoperative cares very well, because this is the most important step of LASIK surgery, making the flap, and rest of the things is done by the laser. So one has to be very much careful. And what to do once free cap has occurred? If suppose the flap is intact, you can, and the stromal weight is more than 6.5 millimeter, that is the intended optical zone, you can just remove it. This free cap can be kept in the desiccated chamber, and you can go ahead with the ablation. And after that, you apply the flap, let it dry for 5 minutes, and apply the BCL. And in some cases, there are chances of flap loss also. If you have not taken care and it has actually been lost or washed away, then you can just leave it, let the cornea heal. It will create some hyperopic shift, and then later it can be PRK can be done. This is one of the small video. This is not intraoperative, which actually this free cap had happened, and I applied BCL after taking all the care after ablating, and the next day the flap actually get little bit dislodged. So this I am just showing that this had happened. The free cap I encountered during the procedure, and next day I encountered another problem. So you have to take care that you reapply it, because there is no mark, so repositioning it is very much difficult. So you are going to have some amount of astigmatism of some power after the procedure. Corneal perforation, though I have not encountered, it can happen. Again, it is very rare, but it's very dreaded complication. If it happens, if there is very small, just stop the suction at that point of time. You can apply the BCL, or if it is large, you have to apply the sutures. But I think that this is one of the dreadest complications. And examer laser ablation related problem or complications can be there, like central island, where you ablate the cornea in a manner that it has left some part unablated. It happens if there is some debris or something on the cornea. Due to paucity of time, I won't go into that detail. There can be decentered ablation. These are minor problems that can be taken care of. But flap creation related problems that are really dangerous and really dreaded. So if there is decentered ablation, you can manage it later on, like if you can apply RGP lenses, myotics to reduce the optical aberration, and you can do topo-guided LASIK or PRK later on. The early complications, one of the patient was very much happy after procedure. After 1 hour, the patient was able to read almost 6/9, and then in the night he called that I am having severe pain and something like that. So I counseled the patient. When the patient came in the early morning 6:30, I could see that the flap has actually dislocated. So this is one of the complications which can be seen next day or very early within few days, and it's mainly because of the trauma or squeezing of the patient, squeezing the eyelids. And this is the same patient. And the next morning I could see that actually the flap has dislodged. So again you have to relift and wash it thoroughly, and let you see that there is no epithelium inside, so there will be risk of epithelial growth actually. Flap striae is again another problem which can be there, which can be one of the nightmares, but if it is detected early, you can very well manage it. And then the problem is that if it comes into the central area, it will just degrade the quality of the vision. So here you have to lift the flap and just wash it, and with 2 sponges you can just milk it perpendicular to the line of the stria. Smaller stria don't create much problem, but the bigger stria create problem. In that case, actually you need to remove the epithelium. Sometimes you have to do actually hot ironing also. Some of the surgeons have reported that. Diffuse lamellar keratitis is one of the complications which can be seen after the procedure, which happens in the interface and causes a lot of problems, and mainly it's because of the glove, talc, marking pain and other things. So that has to be managed. This steroids has to be intensified in those cases. I won't go into that detail already. Macrobial keratitis, again it's very frightening problem or complications which can occur, and I have encountered one patient which had infection about 3-4 days later, and with proper care and antibiotics the things started improving, and at the end of 3 months I could see this. The patient vision was actually 6/12, so I was happy that at least patient I was saved. One complication which I just want to mention, then I will finish my talk, that is the epithelial ingrowth, which can be seen in very few cases, few percentage of cases, but in retreatment cases the incidence of the epithelial ingrowth is more, and majority occurs within first 4 weeks, but it can occur later also. And pathogenesis is just implantation of the epithelial cells in the interface during the procedure, or suppose the patient had some trauma and the flap has dislodged or has misaligned, then epithelial cell can migrate through that. These are the patients who are going to have more chances of epithelial ingrowth. Won't go into the detailed theoretical part. This is just small video. This was patient who came 12 years after the LASIK procedure. Is a CISF person who had some fight with some person, and his this flap was little bit dislodged, and he came with this much of the epithelial ingrowth, and patient vision was just 660. So I took the patient to the operation theater. Then you can see that how easily I can still remove the still I can just take out the flap gently. So there is the healing is in the LASIK flap. The healing is not complete even years and years together. So the principle is that remove all the epithelium from the bed, from the under surface of the epithelium, and not only that, you have to remove epithelium around the flap in the bare area of the normal cornea, so that again there is no chances of migration of the epithelium. And since the patient had history of about 1 week back, about 3 months back, so I had to take sutures so that it does not slip away again and doesn't allow the epithelium to go inside. So I put 310 suture in 3 meridians, and then applied the BCL and this, to my satisfaction, this finished most of the epithelium inside, take care of the epithelium inside. So this is the pre-op picture, this is the post-op. You can see the sutures here, and after removing the sutures about 15 days, you can see the cornea is almost clear. So these complications occurs but can be managed. So take home message is that various complications can occur with the LASIK, and they are really very much frightening to patients as well to the surgeon. However, the rarity of its occurrence results in non-familiarity of most of the ophthalmologists, because most of us are not reporting or not recording. So in-depth knowledge of the complication can help reducing the occurrence, and early identification with appropriate treatment in time can save these eyes from going blind. So reporting complication is necessary, as it is the only way to learn and improve the surgical technique to reduce the complication in future. Thank you so much.
Thank you, Dr. Subhash, for dealing with the complications. Now I'll be dealing with PRK, knowing your limits. So at the outset, I would really thank the scientific committee of AIOS for this instruction course to to share with you, and just the nightmares which were shown by Dr. Subhash definitely has prompted most of the refractive surgeons nowadays to go in for a safer procedure with having peace of mind. Howsoever long you have done the LASIK procedure, the flap complications can trouble you at any point of time after the surgery. So if you keep the limits in mind, what are the problems? The greatest problem in PRK comes is the corneal haze. Corneal haze, and that's more dependent on the amount of refractive correction and the danger of creating an iatrogenic corneal ectasia. These are the things you have to keep in mind, where you need to know your limits, how far are you going. So basically the depth of ablation becomes one of the important factors in these things. Larger the ablation zone, more the depth of ablation. So you have to optimize the optical zone while you are doing a correction. So the ideal is usually larger than the mesopic and scotopic pupil. So usually people keep it at around 6 millimeter diameter, but that too also varies a little with the amount of refractive error. Now this corneal haze, why this problem occurs? This is basically a disruption of the epithelial cells and the basement membrane which is done, and this leads to inflammatory mediator response and the release of growth factors and causing all epithelial stromal remodeling, and these all creates a release of I would say MMP and disorganized, ultimately leading to disorganized organization of different variety of collagen, and this leads to finally a proliferation of the myofibroblasts. That leads to the haze, early or the late ones. Early you definitely have a haze, and late haze also. The reasons are due to these modifications. So the early starts around 1 to 3 months after PRK, and spontaneously resolves with the use of steroids by the end of 6 to 12 months. Then there can be a late haze which starts around 3-5 months, and then that can persist for even more than a year. If there is a scarring, then further interventions may be needed. So this corneal haze is an important factor to limit your decisions while you do the amount of refractive correction. So the risk factors for increased haze, as I already mentioned, is the higher amount of refractive correction. If you go beyond 6 diopters, the chances go more high. And if there is a stromal surface irregularity present, if there is a delayed healing of epithelial defect observed, or an ablation depth more than 75 microns, more liable for haze. And nowadays, these larger spot size, now they are old because of the new machines. Now, retreatment also has increased chances of haze. So these things you have to keep in mind. And one thing has been noted, that there is a lesser incidence of post-operative haze once you are using a transepithelial PRK. as compared to the mechanical debridement. So nowadays, since the advent of mitomycin C, the incidence of corneal haze has gone down. It interferes with the wound healing response and definitely reduces the postoperative haze. It's usually directly applied on the stromal bed after the laser ablation procedure, and the most consensus is around 0.02% for around 30 seconds up to 3 to 4 diopters, and increment of 10 seconds for every diopter thereafter is the consensus. Various studies have been done, but the consensus lies here. And you have to keep in mind of a trend towards overcorrection with the use of MMC. That has to be kept in mind. Now, this is what we need to plan. So the prevention and the management of corneal haze would be routine application of mitomycin C intraoperatively, post-operative use of steroids for at least 6 months. It may extend to even 1 year. Scaling up of steroids and appearance of late haze, and you have to monitor the IOP in cases of steroid responders in these cases. Many patients, a longer use of steroids can cause an increase in IOP. That has also been noticed. And this persistent corneal haze is also one of the reasons of regression. So these things have to be kept in mind. This complication has already been dealt. So the third part, which I would say, is the creation of iatrogenic corneal ectasia, which is done by the refractive surgeons if a proper evaluation is not done. So it's said that corneal biomechanical changes are hypothesized to precede the topographic and tomographic abnormalities. Now, two indices, Corvus biomechanical index and tomographic biomechanical index, had been introduced for early detection of corneal ectatic changes. But the sensitivity and specificity of TBI on integrated pentacam and Corvus ST software in detecting clinical and subclinical cases of keratoconus is found to be superior than CBI. A cutoff value of around 0.2 is demonstrated to have a 90% sensitivity and 96% specificity in subclinical ectasia. 0.7 was a 100% specificity, so 0.2 was a cutoff. Superiority of TBI has been established by different studies in different population. Post-operative refractive evaluation, where you need to see whether it is a stable laser vision correction or not. TBI and CBI was primarily developed to differentiate between a normal and an ectatic eye, but is unsuitable for detecting post-LVC ectasia. This new CBI LVC index performs an automatic assessment of the stability post-laser vision correction and aims to differentiate between a stable LVC case and a post-LVC ectasia. A cutoff of 0.2 was able to separate from a stable LVC with a sensitivity of around 93% and a specificity of 97%. Now, all these factors are to be kept in mind when you are dealing with borderline or a correction of a higher corrections, thinner corneas. So what limits you should have in mind is that when you have a thinner cornea, less than 500 microns, you have to be careful on other parameters. You should aim for a safer residual stromal bed. We at our center usually do not try to go below 300. People have gone less than 250 even, but they do keep it at 250. But we do not go less than 300. If the percentage tissue altered is more than 40%, depending upon the correction, you have to be careful. Deeper ablation, you have to be careful in your limits. So if you keep all these things in mind, you won't find regressions, because these things can be monitored by a decreased uncorrected visual acuity or a focal inferior steepening or irregular epithelial thickness, which Dr. Gayatri had shown in the initial slide on AIOS2025. So if the corneal ectasia is seen, the management is there. Now, you won't like to go in for this after doing a refractive correction in any patient to manage a corneal ectasia. You would like to prevent that. So refractive regression, definitely, despite all things, can happen. It's mainly due to epithelial hyperplasia and stromal remodeling, which can be dealt with scaling up of steroids, and if the other factors are there, that definitely happens. But the incidence varies from 6 to 7 to 13% in PRK patients and 3 to 11% after LASIK. That too is comparable. So I would say why PRK is again gaining. If you keep the things, careful things in your mind, manage the pain, the resurgence of PRK is coming up with the surgeons because of its utility in thinner corneas. All the flap related complications which Dr. Subhash just showed, it's a nightmare for any surgeon, are avoided. Lesser haze is definitely there with the use of adjuvant MMC, and with the modern machines you have all transepithelial profiles and the flying spot laser. All things are modernized and you have more safer procedure to do. We at our center are finding majority of PRK patients coming up with us with their demands. We have gone up to the correction up to -7 diopters with a PTA ranging between 12 to 27%, and 100% patients were having pain the next post-op day as depicted by Dr. Raki, and visual acuity stabilization was 6.6 by 1 week in LASIK, what we found, and in PRK 6.6 by the end of 1 month. So to conclude, I would say if you have the limits in mind of the corneal mapping, thickness, amount of ablation, not creating a corneal ectasia, those parameters, it has got a very easy learning curve. It is cost effective, no blades are required, no surgical nightmare. Excellent results with the use of mitomycin C, and at the end of the day, there is a surgeon's peace of mind. Thank you.